Good afternoon, everyone. We're going to be getting started in just a moment. Just want to give everyone time to enter the room for the webinar today. All right, why don't we get started? Good afternoon again. I'm Jennifer Ryan with Aurora Health Group, and we've been the team supporting the Office of the Surgeon General and DHCS on the ACEs Aware grants to date. We are so pleased to be with you all today to highlight another group of really stellar and excellent grantees, this time focused on our network of care, planning, and implementation grants that have been taking place over the past year. So as always, we have a great panel of presenters, and then we also have California Surgeon General, Dr. Burke Harris, with us to serve as a reactor and listener and just have a chance to be part of the conversation with all of you today. So our panelists will be Heidi Mendenhall, who is the Child Development Executive Director for First 5 Tehama County. Egypt Davis Evans, the Project Director from the Westside Infant and Family Network. And then Dr. Rebecca Rodriguez, also from WIN. And then from Cottage Health, we'll hear from Alma Atiedu, the PERC co-chair and population health program evaluation manager for Cottage Health. So thank you all for joining us today. And I'm going to turn things over to Dr. Burke Harris for a couple of welcoming remarks.
Hi, everyone. Thank you so much for taking the time to share all of your incredible work with me and with our team today. And I say this all the time, so Jen's heard me say this all the time, but for real, this is my favorite part of this job. It is, it's one thing to be in government and doing all the stuff behind the scenes to try and support this work and to try to support our COVID response and all the other stuff, and it's super crazy. But I think that for many of you who have any familiarity with my background, this work is so near and dear to my heart. This is the reason why I came to government. And so when I get the opportunity to hear how all of you are taking that little seedling that we planted in the ground and nurturing it and watching it flower and grow into things that I never could have thought of or dreamed of, right? To literally hear how you all are doing this work and how the work is evolving and getting better and growing from experience and all of that stuff. It literally is my joy. I learned so much from these presentations, and I love to take all the little kernels and nuggets and think about how our collective wisdom is to hear all of your presentations today. And I just really want to thank you for your incredibly hard work that you're doing every day. I appreciate you.
Thanks so much, Dr. Burke Harris. Great way to kick off the conversation. So with that, I will turn the mic over to Heidi Mendenhall from First 5 Tehama.
Hello. Like Jen said, my name is Heidi Mendenhall, and I am the Executive Director of First 5 Tehama. I am also a mother of 2 wonderful young children and the wife of a healthcare provider and the daughter of a first-generation immigrant. And so it was with all these selves that I bring myself to this conversation and am humbled and a little starstruck to be sharing with you. You can go ahead. I am getting to represent this amazing list of partners who came to the table mid-December and said, yes, let's do what we know we need to do for Tehama County. On the left side of the screen is Empower Tehama, our amazing domestic violence prevention support. Expect More Tehama, which is a cradle to career collective. Northern Child Development, Inc., who is our early and Head Start providers. Tehama County Department of Education, that does all things education in Tehama County. Tehama County Department of Social Services, who does all things social services, including community action agency, foster, and other supports. Our health service agency, which just gets a nod of thank you over the last 2 years, Dignity Health, and our 211 NorCal United Way. So it's a miss to not at least say those names out loud, because it was with those partners that we were able to say, where are we at and how can we build a stronger highway of trauma-informed network of care? The picture of Tehama County there is actually painted by a preschool parent, and it was auctioned off at an art fundraiser. And it highlights many of the things that we're also proud of in Tehama County. It also highlights the ruralness of Tehama County. We are around 3,000 square feet. Square miles. We'd be real rural if we were square feet. About 3,000 square miles. We are at the base of a couple mountains, right? We're in this valley piece. We're 33 degrees in the winter, 117 in mid-July. We've got extremes. We have 17 different cities or unincorporated areas, 2 of which are cities and towns, right? And they're all widespread across geographically. And of those 17 different, cities, towns, and unincorporated areas, we have 3 clinics. 3 of those have clinics, not 3 clinics, but 3 of those have clinics. So there's this real wide level of geography diversity. And just strictly in miles, it takes time to get to resources, to get to places, to get to things. You can go ahead and go on. And I say that because it's really important to ground this in who we are as a county. There is huge benefit to being small also. And one of those benefits is that we can really lean in to great work that's already been done and grow up from there. And this is some of that great work. So thinking about that really widespread rural geography and the lack of resources in all those different communities, we have to lean into things like Help Me Grow, our home visitors, our 211 United Way navigators, to get the resources to the people, or quite literally get the people to the resources. And so Help Me Grow Tehama was really one of those building blocks that the Tehama ACEs Aware Collaborative came together and said, we want to build from here. We want to build in what we're doing connected to Help Me Grow Tehama. The Early Intervention Partnership is made up of administrators and really decision makers of anybody that does prevention or intervention. And so we brought this work, this ACEs Aware work, to the Early Intervention Partnership, we refer to it as EIP, and said, we want it to live here. We want it to go on here. We want it to always come back up to the conversation here. And they were 100% on board. And so, that's one way the work lives on. And then third is our Pregnancy to Preschool Partnership, which played a way more critical role than we actually ever dreamed that they would. And this partnership was born in education, right? Born in this idea of preschool. And that, why have a family on multiple wait lists? That just doesn't make sense. So let's make sure if a family's trying to get to care, that we can share that family to whoever has openings, to whoever's enrolling, without putting that onus on the family to call these 8 different numbers. And so in this partnership are home visiting programs that serve pregnant women up through preschool and early TK programs. And so this came up and played a role because of this referral program. You can go ahead and move on, Tilly. Because of the ruralness of us, we had those 8 people at the table, and we had all of the components of a trauma-informed network of care there, right? So we had 8 people, but like I said, when I introduced myself, I'm many things, right? And you can bet I tapped on my husband that's a healthcare provider to say, wait a minute, who else do I miss at this table, right? And so, he had a contract with the hospital. So too is the example on the very left-hand screen is the Expect More Tehama group. Well, they were there via Expect More Tehama, but they also happened to be an administrator at our local job training center and workforce development. So we were able to tap into some federal work that was being done there. And so there's this richness when we are able to bring our whole selves to the table. And in my experience, that happens much more when you are living in a rural area that forces you to do so, right? So you can go ahead and go on. This is a lovely representation of the network of care, and Dr. Burke Harris, you might recognize it from some First 5 work as well. So this was us. This was our first meeting when we came together. And I love this quote because it really exemplifies what we did. Start where you are, use what you have, do what you can. We didn't let perfect get in the way of progress. We didn't have all the pieces and relevancy ready to go to get in the way of moving forward. And because of that, and we were able to accomplish, in my opinion, some pretty amazing things. We came together 3 times. We met multiple other times, but as an official convening, we said, this is our work. What are we going to do? How do we move the needle and create multiple on-ramps to this trauma-informed network of care? The 3 things that came up strong and steady every time was education for all providers, community members, and educators. So, rewinding to, we don't have that many clinics in all the communities. We have to educate the people that are actually with the people, right? So that means educating the home visitors. It means educating enrollment staff. It means educating peer providers of mental health support on this work. Side note, I just learned in county, we had 1 more resignation. So I believe we have 1 non-locum pediatrician in county right now. So it is hard. We have family practitioners and some PAs, but we just don't have the staffing to lean in hard to the medical professionals. We have to be able to build a bridge. We have to be able to funnel for them. And so you would see that in our numbers, that the number of folks that were able to engage in the ACEs Aware training, as well as other community ACEs trainings, had a wide range of roles, right? MFTs, LCSWs, like I mentioned, home visitors, community health workers, all different types of folks that are really, there are connections to the families that are in need and the families that we need to provide our stress busters to. And so the theme is, educate all. And we've already started that. Beyond this planning grant is how do we continue to do that? Well, through multiple different of those 8 partners, they've now built in education pieces for all of their staff aside from the ACEs Aware work. So, we're coming together as a collaborative. We're having this conversation. We're moving the needle. Sorry, think with a pen in my hand sometimes. We're moving the needle. But then we're going back to our homes or back to the ranches and saying, okay, well, how do we do this in our systems? How do we put this into practice in our policy? And that's another one of the great benefits of being able to be so mobile and nimble. Communication across county systems was another big lift. Well, who doesn't want better communication across county systems, right? I mean, that's, of course, yes, please. And with that also came this conversation of referral systems. And so that's where the P2P, the pregnancy to preschool partnership, really got lifted up. And again, because we're all here at this table, some people are like, wait a minute, we have this. We have a referral system. We share families. And then some people are like, wait, what? How does that work? And there became this conversation of, it's really great we have it. And then some folks were like, nah, it's not shiny. It doesn't have bells. I'm not sure it's going to work, right? Because it's not shiny and it doesn't have bells. And so we did some research. We had, conversations with Unite Us and Aunt Bertha and other folks. And at the end, we got to this place where we're like, well, what do we have right now that's working and how can we build from that? And through the support and technical assistance of Aurora Health, at our 3rd convening, we were able to get a technical assistance provider to a neutral party, if you will, and a highly expert party to walk us through a kind of decision-making process of what do we truly need? What do we already have? And at the end, the decision, there were 2 kind of things held. One, we are going to lean into this homegrown online referral system to move the work forward now. We need it now. And 2, well, we are pretty small. So really, we probably need to think regionally for something bigger. And people in the room, Dignity Health and our 211 United Way folks said, oh yeah, we are thinking about that regionally. And we have a goal of 2025. And we were like, excellent. So sign us up to pilot that. Because Shasta always gets the pilots, Tehama never does. So we're trying to get our hand into the pilot jar, and at the same time, continue growing our homegrown system that's already in place, that's already working. We'd already worked through the bugs, and half the members of the group had already signed on to data sharing MOUs with this system. So it wasn't that hard to then add others on. So that was kind of the, some big wins, if you will, to get everybody at the same table and everybody talking the same language. And of course, there are always the questions, do we have enough resources and where are the gaps? Spoiler alert, no, we don't have enough resources. And the gaps are in truly, really mental health, and then also housing and food, right? And so one kind of fun win that we were able to have, a really low hanging fruit, Riatha, our amazing consultant, was able to help us like relook at things and pivot and make just a very small wrap card that has all these community counseling resources on it for low cost, no cost. In fact, I just got a text message from my mother-in-law that she recently, she literally 20 minutes ago got out of using one of those community counseling resources, and she was sharing with me her successes. So, and she literally found them even though she knows me from this wrap card. So, it's sometimes just about getting the information out there. And through this, we're able to think a different way about filling those gaps in resources. You can go ahead and move on, Telly. So this is kind of just our numbers game, and I don't want to sit in here too long, but we were able to provide 58 staff members, including our single, I believe, pediatrician and our other LCSWs and a whole range of folks to get ACEs Aware trained through the online module. Also, we were able to engage our communities through our Cradle to Career, and we were able to have some trauma-informed training, some other ACEs conversations, and we actually, moving forward, not part of the ACEs Aware work, but we also just got to have Mark Brackett come do a training for our community around emotions building out of this ACEs Aware work. So this was a really catalytic thing for our community level conversation. And the other nice, really fortuitous connection was our partnerships, our Medi-Cal partnerships. We're small, and so we're a blip in comparison to other of the counties that these partnerships support, and sometimes we have to knock a lot. And our partnership with ACEs Aware and Aurora Health helped us knock louder and get them to come share with us. And now they're connected to our pregnancy to preschool partnership, and we're able to make some more movement in that realm in the community-based organization support. You can move on. And then this is just our what's next slide. So I'm super proud and excited for March 2nd. We're going to host a Stress Buster Cafe. Came out of this need to train all, to be more connected, to do interagency work. I believe this will be a first annual, and we'll do it annually. It'll be built into the First 5 Tehama work, but also partnerships with our Cradle to Career Collaborative and our Department of Education to get our boots on the ground folks together in one room. And while it's lovely to know the resources they offer, our goal is to have a phone a friend so that we can build the social connections and relationships between those folks so that then we can do the same for the people we serve. And then obviously we are going to continue leveraging our funding and building and seeing what else we can use to embed to implement the trauma-informed network of care. But the beautiful thing about this opportunity to come together and plan was that we are also vested that whether or not there is external funding, the implementation plan will move on and it will go forward.
Thank you so much, Heidi. That was great. What a just really wonderful example of exactly the concept that we hoped everybody would be working on. So I invite all of you in the audience to submit questions into the chat while we're doing the Q&A with Dr. Burke Harris, and we'll try to fit some in, time permitting. But let me turn the mic over to Dr. Burke Harris to start it off.
Thank you so much. That was really helpful. And I had one of the first questions that I had. So one non-locums pediatrician. Wow. So how did you, when you were saying that you guys, what you learned was the importance of the education for all providers, is one of the takeaways there that being in a more rural setting, it's harder to fill those full-time healthcare provider roles, and so having the other members, having the the full kind of healthcare team trained in doing the ACE aware training helps to maintain that continuity?
Absolutely. And it's, right, if everything's based in relationships, it's hard to have a relationship with your provider when they're not long term. And so we need the medical assistants, we need the non-provider clinical staff, right, to be in that same conversation and on board. The behavioral health staff, that was actually a win that happened. One of the clinics hired for the women's health clinic had not had a behavioral health staff, and they hired them during this process, not directly related, but throughout the process. And so that itself has been a great bridge as well.
Wow. Okay. And then one of the questions that came to mind, so you mentioned the gaps, right, in terms of mental health and housing and food. And that was one of the questions that I wanted, that immediately came to my mind, was in terms of your planning process, right? So it's one of the things I'm really interested in is understanding. So it sounds like you guys already had a system that probably half of folks were aware was there, right? Like that's always the case. Half the people are like, oh yeah, we totally have something to already do it. And the other half of the people is like, oh, we've never done this before. How did you all look at assessing or adapting your current system to ensure that follow-up and the accountability around outcomes, right? Because I think one of the things that we highlight with the network of care kind of model is this idea that we're driving towards improved outcomes, right? And so how did you all handle that?
Well, I two ways and still learning, right? So one way is to really lean on our Help Me Grow navigators and our United Way navigators, that both of them in their roles in general is to connect to resources, not case manage, but to connect and then check back and see what else is needed. Are you okay? And 6 months later, check back and see what else is needed. And we were able to kind of merge the data systems that were being used for Help Me Grow United Way navigators through this P2P tracker so that we can all talk the same language. Partly because my role is first 5, partly because we have some really strong leaders in county. 0 to 5 seems to be richer sometimes. And that's where, again, our United Way navigators kind of help play that role in the above ages. The other way that we held on to accountability was through ensuring that it was a closed loop referral system. So we did some work on the homegrown tracker to make sure that if you were getting in contact and if you were providing that service, you were adding that note into the system so that we can pull at any time and see, we had 36 referrals and 12 served, like what's going on. And so that's another piece. The add-on, what I hoped to see eventually is that we actually have a case manager, not a navigator, but a case manager level that can do that relationship follow-up ongoing.
Okay.
Does that answer, or am I not quite hearing the question?
No, that answer. So in part, I think it answers part of the question. I think one of the pieces that I think is really tricky with the network of care is that one of the pieces from the state standpoint is that and this is actually part of the reason why these networks are kind of built around the medical home, right? Because we want to not only ensure that people get served, right? Like if they make a referral, that they got the care that they needed, but we actually want to see that has a positive impact on health outcomes, right?
So the measure would be more along the lines of Yeah, they're more community-based measures. Like we can see developmentally, or we can see if the family strengthening protective factors have increased, but that's where we're at, not the medical outcomes level.
Yeah, so I think that's the hardest part that we have been working on as in trying to bring these systems together, because that's not the way that things are really designed right now. But ultimately, right, that's kind of why we're doing all this work, is to help people be healthier, right?
Yeah.
Like that's why we're putting all these resources into it. And so, and I think that's the piece that's a little bit the hardest to come together around, because it can be the hardest to demonstrate. But this is a big part of the reason why we're bringing all these folks together, right? In healthcare and in early childhood and in mental health and all of the pieces that are part of this network of care, to say, you know, we're really driving towards ensuring that the individuals and the families that are receiving these services, that they're actually ending up getting better health outcomes, right?
Right. No, that's super helpful, and absolutely next phase.
Yeah, but I mean, listen, I also think that it sounds like what you're doing. One of the things I love about working with rural areas is that folks are so scrappy, right? Like there's so many people who are a little bit head cook and bottle washer, which is, I think, really challenging, but I think it also comes from the intimacy and the connections, especially when we do this relationship-based work. I think that in communities where there's just a greater reliance on each other, right? We see incredible innovation. So it sounds like that's what you guys are doing.
Thank you.
Excellent. All right, just in the interest of time, we're going to move to our next presentation, but Heidi, don't go away. We can follow up with you a little bit later with some more questions, time permitting. Next up, we have a spotlight on Westside Infant Family Network, and Egypt Davis Evans, Project Director for WIN, is going to share a little bit about what they're doing.
Thank you so much. Hi, everyone. As mentioned, my name is Egypt Evans. I'm the Project Director here at WIN, and I'm excited to share a little bit about what we've been doing through our ACES Aware Planning Grant, which we are now going by the Los Angeles Resilience Network, or LA Resilience Network. So to start off, I'd like to share a little bit about WIN. As it shows here on the slide, our mission is to empower families with young children to build resilience and thrive through strengthening relationships within families and communities. So our work at WIN has always been focused on relationships, whether that's building community partnerships amongst different community organizations, or really going back to our mission, strengthening those relationships that are safe, stable, and nurturing between family members. And we started our work with ACES back in 2015 with our partner, Venice Family Clinic. They are one of our founding partners and also one of the first partners that we added to our LA Resilience Network. Something else that I'd like to highlight before we jump into our work as the LA Resilience Network is our work as a convener over the years. So we have always made connections between different community organizations. We've often facilitated important discussions to increase the quality and coordination of care for our community. And we've also been a leader of the intergenerational health neighborhood, which formed the foundation for our network as it stands today. And I'll be sharing a little bit more about that throughout this presentation. Next slide, please. So to highlight a little bit about what we did to build our network. So when we first started our planning grant, we already had working relationships with 2 federally qualified health centers in our area. One, as I mentioned before, was Venice Family Clinic, and the other one was Westside Family Health Center. In addition to those relationships, we also had the strength of existing networks in our area to build on. So those included the 3 health neighborhoods that are focused on the west side of Los Angeles, one being led by WIN, the other being led by the Alcott Center for Mental Health, and also Safe Place for Youth. And these health neighborhoods were an initiative by DMH many years ago to convene local mental and physical health providers together to increase information sharing and resource sharing across partners. So to start our network off, we convened all of these health neighborhoods together as one group. We conducted the initial ACEs Aware screening assessments collectively, and then strategized around what resources that we had, which ones were missing from the table. After kind of reviewing that, we also started to work to expand our network to cover the range of buffering supports as outlined by ACEs Aware. So we started to really take stock of who was there, what we had, maybe folks that we had engaged with at one point but were missing from the table now, to really re-engage and show that we had that those strengths across the board. So another important component of our building process was the identification of our shared network, which we decided to move forward with Unite Us. And the way that we did that, we vetted the platforms internally first. And we kind of took those and took presentations to the group as a large group, as our health neighborhood groups, to determine which would be the best for all of us. And eventually, after reviewing each of them very thoroughly and coordinating presentations for everyone to see them firsthand, we went with Unite Us. And we're happy to say that right now we have 4 FQHC partners and 2 other key partners using Unite Us, and we're continuing to try to get others to adopt that as well. Another important building block of our network was the geographic expansion that you'll see here on this slide. So as I mentioned before, our Health Neighborhood Foundation was focused on the west side of Los Angeles, and also the 2 original clinical partners we had were also focused mainly in West Los Angeles as well. But as an organization, WIN does serve South Los Angeles in addition to West, and South Los Angeles is historically under-resourced and generally underserved. And there were also no ACEs Aware grantees in that area when we started our work. So we thought we could really use the connections that we had there, and also leverage our understanding of that community to really expand the work there. So if you look at the map here on this slide, you'll see our original partners and their locations in orange, and then you'll see our geographic expansion into South LA in the green area. Next slide, please. So a few months into the grant, we already had a framework and some lessons learned from working with our partners. And we really thought we could use this to leverage new prospective partners. And we were really able to, as shown on this slide. Can you click to review the rest of the slide, please? Thank you. And the font difference here, there's definitely no difference between the 2. Our new partners are not less significant than the others. Just a little technical change here, but as you can see through this grid, we were really able to expand greatly over the course of the past several months. We now have 5 clinical partners that are Venice Family Clinic, Westside Family Health Center, the Achievable Foundation, UMA Community Clinic, and St. John's Well Child and Family Center. And we also have 3 community-based organization networks in addition to WINS, which include Alcott Center for Mental Health, Safe Place for Youth, and Partners for Children South LA. And as you can see, there is a large difference in the scale of work that these organizations are doing, with the number of organizations that the networks have in their groups, and also the number of patients that our clinics serve on a regular basis. They also were in completely different places in their clinical workflow implementation. They had different approaches to this, and they also had different resources available to them internally, which really impacted the way that they would refer out. Although these were very, very different organizations on different pages, the differences between them really became our major strength. So having this diversity of partners that could learn from one another over time and reduce any duplicated efforts, and also avoid mistakes that maybe others have gone through and worked through and figured out a pathway forward through, was really a benefit to the group as a whole. One example of this is our UMA Community Clinic partner. Very, very early on in the stage of our ACEs Aware grant, they developed several provider trainings and guidelines for trauma-informed implementation of these screenings, and they were able to share those with the rest of our partners that wanted to also refine their providers' approaches. Next slide, please. So that was a brief overview of how we built the network, but I wanted to also highlight the network and some of its components as it stands today. So one of the major components of our LA Resilience Network is our leadership group. So we established this leadership group pretty early on in the process. We were meeting on a monthly basis to really work toward shared goals for this planning process and talk about things like adopting Unite Us, how we would leverage the resources available to us and where people were at in their clinical workflows. And now we are still continuing to meet. It's a space where all of our partners, whether clinical, community-based, or managed care organization, meet together on a bi-monthly basis to share updates regarding their workflows, any data trends that they're seeing, and other resources that can be shared with the group. Our managed care organization partners have been a wonderful addition and great value add to the group. We have had representation from LA Care. They have shared a ton of support and guidance for the Medi-Cal landscape and what ACEs and the referral process could look like in the future. And HealthNet has been a wonderful resource. They've provided several resources for providers as far as trainings, and also a lot of resources for our partners to share with their patients after screening. And in addition to the leadership group, as we have here, it's bi-monthly. Outside of those meetings, WIN makes ourselves available as much as possible to our partners. So we are always trying to make sure that we have that communication flow between us and our partners. We try to also build connections between partners so that they can work together. If any issues arise, if they want to share resources directly, we really try to encourage and support that development of relationship between all of our partners as well. And we have heard from some partners that having this really consistent communication and accountability structure in place has really helped them continue moving the work forward even after the grant period. Another component of our network is our IT platform and our data collection process. So as I mentioned before, we adopted Unite Us pretty early on in the process. And in addition to Unite Us, and really we're now working to figure out how to best leverage the data in Unite Us to further and kind of identify our outcomes, as was discussed before. We've also adopted some bi-monthly reporting structures for our leadership group. So we ask them on a bi-monthly basis to share any trends and data collection that they're seeing. It could be maybe they're seeing a dip in ACEs screenings. We can see why that is and try to explore maybe if other partners are experiencing that as well. Also, we ask them to share more narrative data. So are there challenges or wins with workflows, what's working, what's not working, and also asking for requests for support of the group, and also really asking them for their input for agenda items for our leadership group. So we want our partners to help guide the work and guide our conversation. So we're consistently asking them for what they would like to discuss at these meetings as well. Another data source for our LA Resilience Network is our resource and referral work group. So this resource and referral group, I will share a little bit about in my next section, but this work group reports their information out at leadership group meetings, and the data that they're sharing is more focused on buffering supports, challenges and successes in actually providing families or patients with resources after their screenings, and what's working versus not working in that space, which leads into sharing about this third component that we've highlighted. So the resource and referral work group is something new, and it's a work group that brings together case managers and community health workers across our entire partnership. So we have representation from every clinical partner that was represented on the previous slide. And they come together on a monthly basis to share best practices, any buffering support resources that maybe are hard to find, they're sharing those with the group, so that, again, reducing those duplicated efforts, sharing the wealth of knowledge that each of them have across the partnership. This was not part of our initial plan. It actually came about because after having several leadership meetings where we were wondering about what resources do we need, how is that going, the voices that we really needed were not present. So we really wanted to create a space for the folks actually providing those connections to resources to work together and connect on how the resource and referral process portion of this is going. We have also, in addition to having that space, it's also led by the folks actually doing the work. So the work group is led by our community health worker that's co-located at Westside Family Health Center, and also a board certified behavioral analyst from UMA Community Clinic. So we're very excited to have them continuing that work, and that has been a real hallmark of our project thus far. Next slide, please. So as I briefly mentioned towards the end of that slide, we have a co-located community health worker that's leading our resource and referral work group. And this co-located community health worker is here today. Really excited to have Elizabeth here. And this is part of a pilot program that we launched with Westside Family Health Center in August of this year. And it's focused on providing psychoeducation and referrals for families of children that are being screened for ACEs at their clinic. So just a brief overview of the workflow. After the patient is screened for ACEs, we are screening caregivers of children at their well child visit, which is an annual visit. After they're screened for ACEs, the community health worker conducts a series of psychoeducation sessions with the caregiver and also refers them to any resources or referrals that they need. So the first session always occurs immediately after the well child visit. So she is there right after their visit with their primary care physician. She goes into the same room that they just received their visit, or if it's a virtual visit, she'll step into the room. So it's less disruption for the family. They don't feel like they're being shifted around the clinic. So she's there to provide them with a little bit of information about what the ACEs screening is, why it is important, why it was given to them, and then share some resources and buffering supports depending on the needs of the family. And by the final session of this psychoeducation series, which really varies because it can be the first and last session, or it could be the second or third. It's really based on the needs and wants of the caregiver. The community health worker works with the caregiver to determine what are the next steps. Do they need additional resources? Or do they need other referrals that maybe they need to be connected to? And calls are made there in the room with the caregiver in real time to provide any intake appointments that are needed, or also using Unitas to connect folks to mental health therapy, childcare, food pantry access, or other things. But the hallmark of this is that they're really able to get those resources they need right then and there. And if follow-up is needed, she will make those follow-up calls in the coming weeks after their visit. So since this pilot program is continuously changing, we are currently collecting the data on number of follow-up sessions that are completed, and also the number of referrals that are being provided, what kind of referrals are being provided, and also more of the difficult questions, like if there are a number of screenings being declined, why is that, and how can we further adapt our approach? Next slide. So what's next? Since the grant period ended, we're continuing to refine our best practices. We're also continuing to meet with our group on a regular basis to discuss workflows and also resources and referrals that are needed. And in addition to that, we're also really, again, monitoring closely our pilot program with Westside Family Health Center to see if that's something that other clinics would like to adopt. And additionally looking for other clinics that would like to try the pilot program as well, maybe in different areas with different workflows within their clinics. In addition to this, we're also constantly trying to build out our resources and community connections by learning from our resource and referral work group. We're still using our health neighborhood meetings and other network connections to identify resources. Just last month, we found that one of the buffering supports that were missing was getting outdoors and using the nature to heal. And when we took that question to our health neighborhood, they shared just a plethora of resources that we had never heard of. So we were able to collect all of those resources and share them back with our resource and referral work group for them to be able to share with families. So we've really found that those different connection points within the community have been very useful for gathering the resources that we need. We're also, of course, always encouraging more organizations in our network to adopt Unitas. Our hope is to have everyone on Unitas at some point. We are working towards it. And the more community organizations and other clinics that join, we're seeing that more and more folks are starting to join as they hear about the good experiences from others. And finally, what I wanted to share was we are also advocating for and strategizing around the expansion of mental health services. As Heidi mentioned previously, this planning process has further established what we already knew, that there's an extreme lack of mental health services in our area, and that's only going to increase as we continue screening for ACEs and also referring families to the resources that they need. We'll see that capacity get lower and lower. So right now, WIN is currently working on becoming a Medi-Cal provider through LA Care to offer our mental health services to Medi-Cal members. And we're also using the data collected from our partners and our pilot program to continue advocating for additional funds for those mental health services. So that was an overview of our LA Resilience Network. I'd like to quickly wrap up by thanking Dr. Harris, ACEs Aware, Aurora Health Group, and especially all of our partners and internal staff that have supported us through this process. We're so grateful for this opportunity and are looking forward to continuing the work in the future.
Thanks so much, Egypt. Really quick, just clarifying question before we turn to Dr. Burke Harris. In your clinical partners, are they screening children, adults, or both, or one or the other?
They're screening both. So yeah, they're screening both, and it kind of varies across clinical partners. Westside Family Health Center is screening for both, and there's other partners that are doing one or the other.
Thanks. Dr. Burke
I'm
Harris.
going to ask a follow-up question on that, because there was, I think the question in the chat was, in a pediatric visit, are you screening the child, the parent, or both, right? So some child-serving healthcare settings assess the ACE score for the child, and some assess the ACE score for the parent and the child. Medicaid reimburses for assessing the ACE score of the child, but not the parent if the parent is not a patient of the clinic, right? So if you're in family medicine and you assess the mom's ACEs and she's your patient as well, you can, but that is something. So can you clarify that piece?
Yeah, so it's really depending on the age, and Elizabeth has been screening, and I think Dr. Rodriguez also has been screening, but it depends on the age of the child. Some have declined screenings for their children, but if they're very young and don't want to answer those questions, we found that to be very difficult, and they're more open to answering for themselves. So it really varies. Elizabeth has been offering the Pearl screening for children, but sometimes if that's declined, we'll try to collect data other ways as well.
Please go ahead, Dr. Rodriguez. Is there something you were going to add?
Yeah, I guess maybe I might want to ask a clarification question back in terms of whether the question is, are we screening for ACEs in the child, but we're screening Egypt. We're obviously asking the patient the parent depending on the age, and we're newer in our adoption of ACEs. So just to clarify, we actually started this organizational journey about a year ago. So fairly new. Some of our other partners have been doing it much longer, Venice Family Clinic being one that Wynn has worked with longer. And so we actually grappled with this a little bit in the beginning in terms of whether we were going to screen both, particularly if the parent was a patient of ours at the same time, but we don't at this time. We're screening the child. Although there's a lot of there's evolution, right, in this. And so there has been moments where, and times and situations where we have screened the child, but the parent has actually informed Elizabeth that while the child had not experienced that, they themselves had, and that they had experienced, we had one situation, the parent had experienced discrimination, so not in the ACEs part, but in that life-related events questions after, and would want resources for himself based on that. But that's been sort of situational. It's not routinely we're screening both at a visit.
Thank you. And I part of the reason for clarifying was just because, and maybe Nancy, you can speak up if you'd like to, but when I saw that the question was, are you screening the child, the parent, or both? I think that there are different ways that can be interpreted. Some pediatric clinics screen the parent and the child, assessing them for ACEs in the parent and the child. And some pediatric settings assess ACEs in the child by asking the parent, right? So a parent report of child ACEs, and then some family medicine clinics actually screen the parent and the child. So it's all, you know, for ACEs and the parent and the child. So it's a very contextual answer. So Dr. Rodriguez, I'd be really interested in hearing a bit about, you mentioned that that your clinic just started this about a year ago. I'd be interested in hearing about how that process is going and whether or not the extent to which you think that's impacted your clinical practice.
Oh, certainly I can speak to that. It has been a very positive experience for us organizationally, and with some sort of unforeseen positive gains. So we trained our entire team about a year ago in ACEs, you know, providers or front desk staff, all really every team member, and empowered them with the education around the science of ACEs, the effects of toxic stress. And it was really important because we recognized the pervasiveness amongst our team, but also sort of empowered them with these potential mitigation strategies, which now we've taken forth in our pediatric practice. We also do screen our adult patients separately at some of their visits, targeted population for ACEs screening. But in our pediatric population, we have been doing this now in collaboration with WIN, and it's been really an extraordinary experience because we've been able to, you know, partner with this organization that has expertise. They have a track record in the community of sort of building resiliency in families and focusing on our youngest, most like promising members of the community. And we've been able to leverage some of the expertise that they have in working with other clinical partners that have done this longer than we have. So Venice Family Clinic being one of their major partners before, and they've been doing this now for the last like 6 years. So leveraging some of the expertise and having our co-located community resource specialist, Elizabeth Collin, who's here with us today, has been incredibly, I think, instrumental and critically important in sort of elevating the work that we're able to do as we're just initiating this work. So it really, I think, has been advantageous to our patients and to this clinic. Is to Heidi, who spoke previously, to her point of resources and gaps. You know, whether you're in an urban community or in a rural community, we as healthcare centers still are not one and the same either. And so we have variability in our internal resources. And I work for a smaller federally qualified health center. And so some of our internal you know, support staff capability is not the same as some of our other partners or other FQHCs in the area. So we have really benefited from having Elizabeth Collin here with us. I feel like it allows our patients to recognize how important this work is, right? To have somebody dedicated for this specific work highlights the importance. It's that important, right? That we identify, recognize, address the effects of toxic stress. And not only here, but it shows then that it's not just Dr. Rodriguez, it's not just Westside Family Health, it's not just WIN, but it's a like greater, broader community that is coming together because she has this network of care to connect patients to. So I feel it's been just a fantastic experience, and has, in terms of answering your question about how it's changing my clinical practice, I would say that it is slowly transforming how I provide care. As I think as a pediatrician, I've always thought of like support systems, right? We think of nutrition, exercise, sleep. We're talking about all these things and assessing them at all visits, particularly our wellness visits, as importance for health and for being healthy. But now it's transforming for me as like, instead of just importance for health, it's actually treatment, right? Treatment for potential biological changes that have occurred because of stress, which that is a complete shift for me. It's not just, these are good things to have. These are actually healing things. These can change things, which that was not my clinical practice before. So.
Well, that's exciting for me to hear. That very much warms my heart, especially as we think about, and we answer some of these questions about how do we do this work, I think your point is very well taken. These are things that we, as child serving clinicians, we already assess for in the visit, right? Like we already ask about these things, but how we frame, how we deploy the same tools in clinical practice makes a big difference as to how we help our patients understand and respond to some of the challenging experiences and exposures that they have, and how they can impact health and what we can do about it. So much of how we address these challenges are resources that are already at our fingertips, right? Either in the clinical work that we're doing or in the community. So I'd love to hear a little bit from Elizabeth about your work in connecting families to resources in the community.
Yes, of course. So to start off, I think the relationship that Westside Family Health Center has with their patients has allowed me to build rapport with them. Right after the ACEs screening, I'm able to have the first interaction with them and talk, right, what is the purpose of the screening? Why are we doing it? Then through that session, I'm able to also follow up with them and even open up more conversations around clarifying, right, questions about toxic stress, ACEs, building a self-care plan, identifying like what are the healthy relationships within the child's life. So I think even that has allowed us to kind of start these conversations, and families feel comfortable to say, hey, I need assistance with housing, or I'm having difficulty providing food at my house, right? And then getting them connecting to food banks. So I think being present at the clinic, right, has allowed patients to feel more comfortable and just identifying like that one person they can go to. And then making sure that I can also close the loop around the resources, right? Like as we mentioned, we're using Unitas as a platform to do those referrals for resources. If we don't have them internally at WIN or at the clinic, that has been great for us to make sure like they're getting connected, and our partners are actually in contact with the patient, and we kind of close the loop in that way. Honestly, I've been lucky to have great feedback from patients, and little by little continuing to build that rapport with them. And sometimes I've had resources that are not necessarily for like themselves, like the adult or the child. They've even asked me like, oh, I have a cousin that is probably dealing with substance abuse. Can you please assist me with anything that I can, provide them with? And so I think it's been a great experience, like so far. And I hope, continue the work with the clinic, and then continue to also make an impact in the families, and, hopefully, mitigating the toxic stress or challenges that families have faced. So, yeah.
I can't tell you how happy it makes me to have a conversation about helping families build a self-care plan. Like that is my dream. And I one of the pieces that I will just say as a final piece of ACEs Aware, where I'm hoping to get to, and I don't know, but I will ask maybe Elizabeth and Dr. Rodriguez if you guys feel like, so here's a dream as far as I'm concerned, right? For our families who are struggling, right, it's really clear, or who have, ACE-associated health conditions, it's really clear. And then we're doing this work to connect them to the interventions. What my dream is to also be able to identify our families that are high risk, right, and help them double down on their strengths and really be able to do this work in a way that does, prevention, that early intervention, and the treatment when it's necessary. I think the treatment part is the part that's kind of most clear to folks. You have someone who has a mental health condition or who has an ACE-associated health condition, and you're going to treat it, and you're going to see how it goes. How do you all see any inkling of some of that early detection, early intervention with with a focus more towards prevention. Is that happening yet?
I would answer and say, yes, I'm so on board with this with you. I mean, I think that just in the short time that we have been doing it at Westside, I was going to mention it's not, exactly scientific, but Elizabeth and I, collaborate a lot. Her being present, it's really helpful in that regard. But we I feel like she's intervening in when we have ACEs scores of 0 often, right? Because the ACEs score is 0, but some of the other questions are positive, or even if the other questions aren't positive, or say there's one that's positive, well, then we know they're already at increased risk because those other questions are getting at the other risk factors, the housing insecurities, the discrimination, other stressors that are risk factors for ACEs. So could we eventually prevent ACEs by training ACEs even when they're 0, do that, right? Even when they're 0, get them those buffering into those buffering systems, right? So would be tremendous.
Oh my God.
That's my hope.
I love it. I love it. That makes me so happy. Thank you all so much that it's thrilling to hear what you're doing. It's awesome.
Thank you.
Thank you. Great conversation. And again, hopefully we can come back around for a little Q&A at the end from the audience. Just to keep us a little bit on time here, I'm going to turn to Ama Atiedu from Cottage Health to share a little bit about their implementation grant. And Cottage Health is also a round 1 training grantee, so they have kind of a unique situation. Ama?
Great. Hi, Dr. Burke Harris, and good afternoon, everyone. Again, my name is Ama Atiedu, and I'm with Cottage Health. Cottage Health received a Network of Care implementation grant on behalf of the Pediatric Resiliency Collaborative and Resilient Santa Barbara County. These are 2 local networks working on ACEs efforts in our community, and together we formed the Santa Barbara County Network of Care, and we're so honored to have been selected for today's Grantee Spotlight. Next slide. And actually we can go, perfect. So we've organized our presentation by our key learnings to date. So I'll be highlighting the importance of intentional trust and relationship building, which has been the focus of all our grant efforts. I'll also talk about the value in building on prior successes, such as how we've capitalized on existing networks and ACEs efforts in our county and our round 1 ACEs Aware grants. And then I'll talk about the strengths of an integrated and aligned approach that we've taken for our training framework, as well as how we're working on ACEs screening and response. And then lastly, I'll talk about the effort and flexibility needed for equity and inclusion to expand our network to ensure that there's geographic representation of all regions in our network of care work. Next slide. So Santa Barbara County has a culture of collaboration with many networks working together. When we were putting together our proposal for the Network of Care implementation grant, it was important for us to honor, align, and expand on these existing networks. 2 networks in particular that came together were Resilient Santa Barbara County and the Pediatric Resiliency Collaborative. So Resilient Santa Barbara County is a network of community partners that are committed to being ACEs informed and trauma responsive. And then the Pediatric Resiliency Collaborative is a community partnership that's focused on expanding ACEs screening and referral services to all pediatric clinics. So you have Resilient Santa Barbara County that really has the community piece, the Pediatric Resiliency Collaborative that had the clinic piece. So it was a match made in heaven for us to come together and work on this Network of Care implementation grant. We also have been fortunate to partner with our local managed care entity, SynCal. And we've had existing relationships with them. They have sat on our steering committee for the Pediatric Resiliency Collaborative. We developed a multi-sector leadership committee that drew on the leadership from the 2 networks that I mentioned before, Resilient Santa Barbara County and PERC. And this was really helpful to build on the trust and relationships that had already been established in these networks. Our managed care entity partner, SynCal, is also a part of our leadership committee. When it came to selecting an IT referral platform to support this work, we engaged our community partners We knew that community buy-in and trust would be critical for success. So we were intentional about allowing time to do focus groups and interviews with parents and community organizations. We sought their input in the selection of our IT referral platform and invited them to be on our advisory committee. We're excited that we are very close to announcing our IT referral platform and couldn't have done it without our community partners, and really excited about what this will lead to in our community. And then lastly, we were intentional about fostering relationships and trust as we introduced new community partners to our network of care through our buffering services grants. So these were grants that were offered to community organizations that provided services that help to mitigate the toxic stress response and really fall within the stress buster wheel, which many of us are familiar with. So these grantees were provided support connecting to our clinic partners. For some, they didn't have existing relationships. So we were starting to form those relationships, and for others, just continue to strengthen them, and as well as getting them connected to other community partners in our network. Next slide. So in terms of building on previous successes, we're really fortunate in Santa Barbara County that we have a history of ACEs and resilience work. Just to provide a brief overview of this history, in 2016, the Kids Network and community partners developed Bridges to Resilience. This is an annual conference that's dedicated to informing multidisciplinary audiences about ACEs and resilience. At the same time, we had a research project launch in Santa Barbara County. The Santa Barbara Resiliency Project really pioneered ACEs screening and response in the pediatric primary care setting in our county. This research study was led by the Santa Barbara Neighborhood Clinics in partnership with CALM, which is a behavioral health organization, and UCSB. And then in 2018, the Pediatric Resiliency Collaborative was established, and we built on the learnings from the Santa Barbara Resiliency Project, that research study, to support other pediatric clinics interested in doing ACEs screening. I'll also just note that we received ACEs Aware Round 1 grants, both PERC and Resilient Santa Barbara, and we've been able to build on these successes for our implementation grant. So Resilient Santa Barbara County received the Provider Engagement Grant, and as a part of the Bridges to Resilience conference that year, they introduced affinity groups, and these are kind of focused conversations where they brought topic experts and conference participants to have conversations around key concerns and local resources. And so we're bringing this model into our network of care training framework. The Pediatric Resiliency Collaborative had the core training grant, and we developed 4 modules for our core training, which we're super excited about. It's going to be on a web portal really soon, and can't wait to have this out for many providers to use. And so for our network of care grant, we built on this by adapting it to have language that speaks to our community partners, so that there's shared language and common goals across all sectors of our network. And so now I'll just play a really brief 1-minute video that outlines our training framework. Through the support of the ACEs Aware initiative, the Pediatric Resiliency Collaborative, or PERC, and Resilient Santa Barbara County have formed the Santa Barbara County Network of Care and developed a framework for training clinics as well as our community partners. The trainings aim to increase awareness of ACEs and provide shared language and common goals across all sectors of our network of care. PERC has trained more than 130 pediatric providers and clinic staff, beginning with 5 clinics throughout the county. Staff appreciate the clinic-wide approach, technical assistance from PERC staff, and ongoing consultation with community partners. Core trainings were adapted for community organizations participating in buffering service grants and the Network of Care Leadership Committee. Trainings feature members of our network and will be available with additional resources through our training web portal. The Network of Care grows stronger every day with our continued efforts to connect and collaborate. Together, we forge a path towards our vision, a county where families and children are healthy, resilient, and thriving in their communities. Thanks so much for indulging us in that video. It's so obnoxious. It's my voice, and now it's my voice again. But we'll get done with the presentation soon so we can hear other voices. So I'll just quickly share our integrated.
Oh, I'm sorry. I'm going to interrupt you right there. I love hearing your voice. I love hearing what you're doing. So don't even go there with that.
Oh, I so appreciate that. So we'll talk really quickly about our network of care approach for ACEs screening and response. And this really began with the innovative model that the Pediatric Resiliency Collaborative started. And so if you're looking at the left-hand side, it really started with pediatric providers. So the Pediatric Resiliency Collaborative, or PERC, provides training and technical assistance to the entire clinic around ACEs screening and referral. In addition to providing the training and technical assistance, PERC provides connection to a designated resource navigator and a therapist that are co-located at the clinic site. When it wasn't safe to do so, these services were provided virtually, and providers started screening families with children in the age range of 0 to 3. We do screen both the child through using the PEARLS tool and the parent at the pediatric visit, at the well child visit. So this was our initial PERC model, right? We have these providers who their clinic is trained on ACEs screening, they're screening 0 to 3, and then referring to these navigators and therapists to provide brief parenting interventions, resource navigation, and therapeutic support. Now, through the Network of Care Implementation Grant, we've been able to integrate additional trauma-informed buffering services. And so these are buffering services grants. And now providers can not only refer to the navigator and the therapist, they can also refer to these buffering services. And they can refer families with children 0 to 18. So really expanding the resources available. And there have been such interesting and innovative programs, things like exposure to nature. We have a school partnership where they're offering friendship circles for students who don't need individualized counseling support. And so I'm doing some social emotional learning in a group setting. So we're just so excited to have this expansion. The other thing I'll note about this model is that it's, it really hinges on this team approach. So we have monthly case consult meetings with each clinic provider and their designated navigator and therapist, and when appropriate, these buffering service grants, so that they can talk through referrals as well as any challenging experiences. Next slide. So lastly, I'll just talk about how we're expanding our network of care with a focus on equity and inclusion. It's important to just give you some context around Santa Barbara's geography. The county is really broken up into 3 regions: South, Mid, and North County. And if you're looking at the upper right corner of the map, that consists of the Los Padres National Forest. So there's not a lot of it's not highly populated, so there's not a lot of activity in that area of the map. So when we started in 2020, the Pediatric Resiliency Collaborative had some existing clinic partners. And as you can see, we were kind of heavily focused in the coastal area of South Santa Barbara County. And we did have some reach in Mid-County with our partnership with Dr. Cindy Bleifeld, who is a private practice pediatrician. And so North County has been an area of focus for our expansion. Other thing just to note is that these individual circles are to scale with the number of pediatric Medi-Cal members at each clinic. So essentially, the bigger the circle, the more pediatric Medi-Cal members they serve. Next slide. So we were able to, with our, once we started our Network of Care Implementation Grant, we expanded in North County. So you can see that dot with Santa Maria Healthcare Center, which is a public health clinic. And then we also expanded in the coastal area with Carpinteria Healthcare Center at the bottom right side of the map. Next slide. So this is really, really exciting. I just have to take a minute here. So we partnered with our managed care entity, CenCal, to really develop an outreach approach that would allow us to expand throughout our county. And so we identified these clinic partners, and I'm excited that we've already had conversations with most of them here. And if we are able to reach all of these partners, those in the yellow, we would have reached 70% of the pediatric Medi-Cal population in our county. So that's our goal. That's what we're working towards. And really, really confident that this can become a reality in our county. Next slide. So this just depicts where our buffering services grants are in relation to our clinic partners. Next slide. And we are excited to announce that we launched the second round of our buffering service grants. So you'll see in stars the potential prospective buffering services. So really starting to see this network grow and expand. Next slide. So we thank you so much, Dr. Burke Harris, for your commitment, your passion for this work. We thank you for your support to Santa Barbara County. And now I'll be joined by my grant management team who will help me answer questions so we can hear some more voices. This amazing team has really helped to guide our grant work. Thank you.
Thank you so much, Amma. Just in the interest of time, Dr. Burke Harris, I'll let you jump in with your questions.
Thank you so much. That was fantastic. And it is, I don't know if any of you guys saw my eyes kind of pop out of my head when those yellow circles popped up, but it was really, it's so impressive. It's very exciting to see all the work that you all are undertaking. And again, I really want to, I can't underscore enough how much, like, I myself, having done it, like having done the work with patients in communities, like I know how hard this work is. And so when I look at all that you're accomplishing, I'm just so impressed. And I'm just humbled. I'm really, really excited. So I would love to, Dr. Ruth, it's great to see you. Do you have anything that you want to add or lift up about this work?
Well, I agree with what you said earlier. I've begun to think that this is really about doing what I've always been doing, but doing it in a better way through a lens that helps families feel empowered to understand why they want to ask for services. And, we've seen these, when you talked about prevention, we enroll all these parents in a 4-session parenting intervention. And then when they're done, they say, I want more. Like, I never learned this before. I want more, and so it's, I can't imagine going back now where we are. So it's really just trying to find, other members of the team can speak to the sustainability, but it's the other thing I guess I would elevate when you asked about the medical interventions, using the stress buster wheel, we like to call it, and having actual interventions to refer families to is really helpful when we're talking about, these evidence-based strategies to mitigate the effects of toxic stress. In the chat, I saw questions about what types of services. Again, we have a wilderness youth project. In our next round, we have yoga, we have some healthy cooking classes in an area of the county that's very under-resourced. Mindfulness, all of those things. I think that wheel is very helpful. And we've asked our grantees to pick and choose where they fall on the wheel when they apply.
Oh my God, you guys. So I just have to say this, like, as each of these groups has presented, what it reminds me a little bit, and when I made that comment, like, so much of this stuff is stuff that already exists. It's just the way that we're bringing them together, contextualizing them and deploying them. It just reminds me, and this is going to sound crazy, it reminds me of my iPhone, right? Because I remember my first iPhone. Everybody remember your first iPhone? It was like, it was like this big and the screen was glass. So if you dropped it, the screen would shatter, right? And guess what? The internet existed before that. A camera existed before that. The cell phone existed before that. But what Apple did was they took them and put them all together in a way that they had not been put together before. They didn't invent anything new. I mean, they obviously invented the iPhone, but they didn't, none of the services that were available in that phone was something that never existed before. And this is what we are doing, y'all. And I say we, but I mean you. This is what you are doing, is that for every iteration, every time you guys work through this, for one, it's going to be the iPhone 2, right? Then somebody else comes out with the iPhone 3. Then next, you know, you're going to be at the iPhone, whatever the newest one is. I don't have it, but about the 12 Max or something. I don't. And anyways, the point is that it's boss. And every time we do it, it gets faster. We problem solve, we work through the bugs, we work through the kinks, right? And this is what we're hearing from our teams at Tehama, to our teams in Los Angeles, to what y'all are doing in Santa Barbara, is that as we progressively move through this process, we're updating and upgrading and working out the kinks and making it a little better. And are there still challenges? Sure there are. But every time through your innovation, this is the definition of innovation, is that we work through these challenges, and you guys are on the leading edge of doing that. So I know I'm supposed to be asking a question, but this makes me so excited. I'm so proud of you guys. And I'm humbled. So here's my question. And this is like, what do you need? This is something that I also wanted to ask Wynn as well. Like, what resources that would facilitate this work, right? I know the answer is always money, outside of money, because I'm just saying, what resources that would facilitate this work is kind of your most pressing need?
You want me to take a stab?
Yeah, Barb.
Okay. So I think one of the beautiful things that you're talking about is by having the ACEs Aware framework and resources and materials, we have been able to help people see, I'm not just doing things that help kids and families. I'm buffering toxic stress. So I'm a stress buster, so we have this common language, and it's not quite fitting yet for educators. And so we'd love some tools to help us connect with education and with like the juvenile justice system. Like they're partners and they're in it with us. But if we could have a little bit more in terms of those uniting resources that help us speak the language in every sector, that is super, super helpful.
Well, as someone working in government for not very long, but whatever, someone working in government, oftentimes we ask the question, what do you need? And people say stuff and we're like, there's no way we can do that. But I am happy to say that my office is actually working on a training for ACEs and about ACEs and toxic stress for educators, that we're working with the Board of Education and the California Department of Education to incorporate into training for educators. And literally just yesterday, I was saying to my team, we need to build this off of our network of care implementation, the work that we're doing, because what educators are asking for is please say that we don't have to solve this all by ourselves. Right? And the whole point of the network of care roadmap is to help people understand what are their roles, how do we connect to each other, so yes, that is easy. And in fact, Barb Finch, I'm writing this down right now. Okay, I will ask my team to follow up with you. In fact, I'm going to ask Jen Ryan right now, because don't make it something I have to do later. Jen Ryan, can you please follow up and connect Yana Olson-Morgan with Barb Finch to start having this conversation about how we build our educators more strongly, how we use the network of care roadmap as a jumping off point for the training that we're doing for our educators?
It'd be my
Very
pleasure.
happy.
Yes, of
I just
course.
gave you more work, Barb, but
It's
I hope
okay.
you-
It's okay. You know, like I feel like there's still silos, you know, and as we build these trusting relationships, those silos start to dissolve. And if we can connect medical providers like our pediatricians with the schools, that's going to be powerful, you know, like it's just so great to see these connections being woven throughout our community. We love it.
Oh, I'm so excited. Really quickly, I'm gonna, because I can't type and speak at the same time. Stacy, yes, this does include trauma-informed school environments and discipline practices. We're looking at the multi-tiered system of support, what goes out to everyone, what goes out to those with higher needs, what goes out to those with the highest needs. So yes. And the last thing I'm gonna say, I know we're at time. I know we don't have enough time for all the questions that we need. But I want to say this to you guys. I am so humbled to be in service to you all and the work that you are doing every day. I literally had today a conflict that just popped up on my calendar, which was a briefing on Omicron. And I was like, I asked my chief of staff to go to the Omicron briefing. Because I'm just like, I have to be at this meeting. But I really, 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 really have to say it. I'm just so grateful. I am so grateful for the work that you guys are doing. It's so beautiful to see this work happening in a way that is, you know, scrappy and all hands on deck in Tehama and moving forward and bringing in partners in LA. And then all I have to say is those yellow circles, right? In Santa Barbara, and just hearing people talking about building a self-care plan, helping our patients build a self-care plan, and having buffering services grants. Hello, like this. I'm just gonna say, I know I'm not supposed to be this animated because I'm in government, but I love you guys. I love this work. I love what you're doing. And we have never needed this more than right now coming out of COVID-19. You guys, it could not be more timely. So I know the work is hard, and I just want to tell you, keep doing it. Keep doing it, because we appreciate you. I appreciate you. And there are a lot of people sending me messages every day that say they appreciate you and the work is making a difference. So thank you.
It's a mic drop. Thank you, everyone. Another amazing session. Thank you so much, Nadine. This is just a great way to end a day, end a Tuesday. Thank you all to our presenters and discussants and everyone that participated today. It was just really, really inspiring. And as always, but once again, so great to see the vision playing out in the real world. So thank you all so much.
Thank you, everybody.